Live. Imar, hola, how are you doing? Lion the Prey, welcome. Yeah, let's tap up the screen. Coming on and not going to tap up the screen by the time I start answer question. So thank you so much, Pandy, for doing that. You're so adorable. Thank you for sharing up the live. And if you need the full videos for the live stream, they're posted on YouTube at Think Nurse in one whole, the same, as the handle here on TikTok. So you can go ahead and subscribe to the page over there and get the full live streams. All right. So the question here, 28-year-old, gravida 2, para 1, gestational age of 34 weeks, severe preeclampsia. Patient is on magnesium sulfate infusion. And as I say, this is an electrolyte, fluid and electrolyte imbalance question. Lactated ringers going at 75 mils per hour. Blood pressure is this so? Hold on it. Did we do this question the other day? Why this question look familiar? Hold on there. Wondering if this is the right slide I'm doing. All right, let me continue. I think it looks like the one that we did the other day. Assessment find vital signs 178/112, heart rate 88, respiratory rate 11. Assessment findings with your deep tendon reflexes diminish, decrease urine output 20 mils per hour. The labs: magnesium 7.8 milligrams per deciliter, creatinine 1.6 milligrams per deciliter. And then we're gonna identify the cue here, select all that apply. Which findings indicate magnesium sulfate toxicity? Which finding indicates magnesium sulfate toxicity? You'll just go ahead and put your answer. A, respiratory rate of 11. B, 178/112. C, decreased DTR, deep tendon reflexes, urine output of 20 mils per hour, or magnesium level of 7.8. Which of these indicate magnesium toxicity? Nurse Jones, welcome. ACE. Probiotics says C. And remember, for you select all that apply. If you don't know it, you just don't know it. Remember, you lose answer or points for your incorrect answer. So whatever it is that you're sure of, you just go with it. So if it is just one, you just stick with your one, okay? So we have ACE, probiotics, Nurse Jones, okay. So nice, respiratory rate 11, your decreased tendon reflexes, urine output that is less than 20, and your magnesium level that is elevated. Pandidorable, yes, ACDE. So the respiratory rate less than 12, respiratory depression, and we know that the absent or decreased reflexes usually indicates your toxicity. Low urine output, we want it to be anything that is greater than 30 mils per hour. Okay, and your therapeutic range for your magnesium is going to be 4 to 7 milligrams per deciliter. And the blood pressure is expected with your preeclampsia. And if the patient, with magnesium, this will also help with their blood pressure because it will dilate it and drop the blood pressure as well. She's preeclamptic, yes. Okay, so okay, let's move on to the other part of the question. What is the greatest immediate risk of this patient or to this patient? A, seizure activity. B, cerebral hemorrhage. C, respiratory arrest. Or D, placental abruption. What is the greatest risk or immediate risk for this patient? You have a patient with all of those abnormal vital signs and lab. What are you concerned about? Carousel says C. Oh, let me go over here. So, Carousel says C. Joy. . Otio says A. Seizure. Okay. Nurse Jones says A. Probiotics says A. So C, Panda, Durable, and Carousel. Carousel, why you say C? Why respiratory arrest? Why are you concerned about respiratory arrest for this patient? Why respiratory arrest for this patient? So we have the scenario here. It's a pregnant patient, gravida 2, para 1, gestational 34 weeks, preeclampsia, severe preeclampsia. All right, why you're concerned about respiratory arrest with this patient? Magnesium elevated at 7.8, creatinine 1.6, diminished deep tendon reflexes. All vitals are down, so I don't think she can seize. Okay, but she has respiratory rate, heart rate, blood pressure. She's severe preeclampsia. What is the greatest risk for your patient with severe preeclampsia? We're giving her magnesium sulfate. So why are we giving her magnesium sulfate? All vitals are done, so I don't think she will seize. So respiratory arrest. I thought the question was a follow-up to the toxicity. It's a follow-up to the toxicity. Affects the respiratory system. Okay. All right. So the immediate risk for this patient is the respiratory arrest. So remember, this patient is already on the magnesium sulfate, which causes the respiratory failure. Okay, so the risk for seizure is already reduced with your magnesium sulfate. So airway, breathing, circulation is what you want to address, and then from there. Christopher, welcome, welcome, welcome. Okay. So who else had said the C again? There were 2 persons, Carousel and Pandidorable. Okay. Let's go on to question 3 here. Which problem requires immediate intervention? Which problem requires immediate intervention? A, hypertension. B, magnesium toxicity. C, risk for fetal hypoxia. Or D, fluid overload. Which intervention requires immediate intervention? Hypertension, magnesium toxicity, the risk for fetal hypoxia, or D, fluid overload. So I see C, Nurse Jones, Sonam, probiotics, C, okay. B, because airway comes before circulation, NAB. I'll put this over here. So which problem requires immediate intervention? Is the hypertension, the magnesium toxicity, the risk for fetal hypoxia, or D, the fluid overload? So we're going to use the airway, breathing, circulation. So is the hypertension, the 178/1 teens, the magnesium toxicity with the respiratory depression? Is it the risk for fetal hypoxia, or D, the fluid overload? So Carmiel, welcome. C, Elizum says C, risk for fetal hypoxia. And then ACOM says fluid overload, your magnesium toxicity, because remember, the patient is already depressed because of the magnesium, okay? So that is going to cause the patient to stop breathing. So you want to go ahead and address that one. And then C is a risk. So, you know, you want to be concerned about it, but that is not like an actual concern or actual diagnosis you want to be like, you know, focusing on right now. So unless something else is going on, but you want to address your actual concerns or actual diagnosis. So we already know that this patient has magnesium toxicity. There is a high risk for the patient not breathing, or the patient is not breathing properly, because we know that the respiratory rate was what, 11. So go ahead and address that one first, and then from there. Blood pressure control is very important, but it's secondary. You need to keep mother safe. And one thing they always say is once you resuscitate the mother, once you stabilize the mother, you stabilize the baby. So treat the mother, you automatically treat the baby. All right, so once the mother is perfused, well oxygenated, then that is the same thing that is happening with the baby. Okay. I would say B. Christopher says B. Yes, Christopher, that's the answer. Okay. Let's go on to, I see when the question need immediate action. Risk choice are not the best answer. No probiotics. Always look for your actual diagnosis and deal with those first, and then you can look for any risk and, deal with that afterwards. What should the nurse do first? So the scenario that we have, we already identified that this patient is already having too much magnesium on board. What should the nurse do first? Stop the magnesium infusion. B, and select all that apply. Stop the magnesium infusion. B, administer calcium gluconate. C, notify the provider. D, apply oxygen. E, increase IV fluids. So what should the nurse do first for this patient? Probiotics says all the above. What should the nurse do first? B, C, D. So B, C, D. Administer calcium, notify provider, apply oxygen. A, C, D. Yeah, A has to be a part of it. So A, C, D, A, B, C, D. Joy Otio, welcome. Pandidorable, A, B, C, D. Okay, A, C, D. What should the nurse do first? Except E, increase IV fluids. Okay, A, B, C, D, definitely. You want to go ahead, stop the infusion. So if you're supposed to get the question wrong, make sure say. Yeah, so make sure you don't get this question wrong. What should you do first? Stop the infusion. Make sure you stop the infusion for your magnesium toxicity there. So stop the infusion immediately. Administer your antidote, your calcium gluconate. Provider needs to be informed. And you also give oxygen to help with, your respiration, supporting your respiration. And then the increase of your fluid is just going to worsen the overload that is going on. Okay. I was thinking IV fluid can increase the absorption of antidote. No, it's just going to increase the overload. Okay. Let's move on to this question. Elysium, welcome, welcome, welcome. Okay. Which finding indicates effective treatment? So whatever you did earlier, which finding indicates effective treatment for this patient? The respiratory rate increases to 16. Your deep tendon reflexes return to positive 2. Your urine output improves to 35 mils per hour. Blood pressure decreases to 150/96. And your magnesium level is now at 6.0. So which findings indicate effective treatment for this mag toxicity? A, B, E, Christopher. And then I have Na, says A, B, E, B, D, E, Nurse Jones, B, BDE, ABCE, probiotics, joy, and pandy. Okay. Carousel ABCE. Okay. So which finding indicates effective treatment ABCE? Your respiratory rate increases to 16 because remember it was at 11. Your deep tendon reflexes returning to +2. Your urine output improving to 35 mils per hour. And your magnesium level is now at a 6. Blood pressure decreases to 150. That's a good sign, okay? Blood pressure, you know, that drop. But in terms of your effectiveness for your magnesium toxicity, those would have been the best selection. All right. So respiratory rate normalized, reflexes restored, adequate renal clearance, magnesium is back in the therapeutic range, and your blood pressure control is a separate priority. So that's totally different for your mag. Good. And just remember, for your magnesium toxicity, you're looking at a respiratory rate that is less than 12, absent deep tendon reflexes. Your urine is usually decreased, and magnesium is usually greater than 7. And the antidote, as we said earlier, is your magnesium calcium gluconate. Always keep the calcium gluconate at the bedside for these patients. You want your urine output to be greater than 30 mils per hour, and airway is very, very important. Blood pressure, then you look at the fetus, okay? So airway, blood pressure, then the fetus is last. Because the fetus is going to be what? Risk. These are actual problems. So deal with these, and then you can always deal with your risk there. All right, let's stop up the live, share the live. Thank you, and thank you guys for joining in. Remember to subscribe and follow. On YouTube, the full live streams will be placed there, just in case you want to come back later on, okay? Let's look at this little kiddo. This is a pediatric, and it is we're still doing electrolyte, fluid and electrolyte question here. So it's an 18 months old. 18 months old, weighs 10 kilogram. How much pound is this? 10 kilogram is how much? I'm lost what I just reached. Oh, you reached just in time, teddy bear. How much pound is 10 kilograms? So we have this little kiddo here, 10 kilograms. How much pound is this baby? Christopher says 22 pounds. Probiotics say. Okay, Carousel says 22. Yes. So what you do, you multiply by your 2.2, right? To get to your pounds. Good. So we have this little kiddo, 10 kilograms or 22 pounds. History of acute gastroenteritis. So vomiting. We don't see pounds here. Oh no, we're in the US now, but we just still need to have an idea how to calculate it. So acute gastroenteritis. So this baby having vomiting and diarrhea for 3 days. How do we define diarrhea? How do we define diarrhea? What is diarrhea? How do we define diarrhea? Frequent, watery. So when they come in and say, well, you know, the baby have 2 stool yesterday. The baby had 2 stool yesterday. Can you treat the baby for diarrhea? Pandy, yes, more than 5 or 6 stool More than 6 stool, yes. It has to be more than the 6 stool per day. And it has to be the watery loose. Yeah, good. Okay. So the history of gastroenteritis, vomiting, diarrhea for 3 days. The baby intake is poor. Vital signs, heart rate of 168, respiratory rate of 38, blood pressure of 78/42, temperature of 101.8. Assessment is showing sunken fontanelle, dry mucous membranes, there's no tears when crying, capillary refill of 4 seconds. The labs are showing sodium 158 milliequivalent per liter, potassium of 4.2, BUN 36, and creatinine 0.9. What is this showing? Joy Otio says dehydration. Nice. Okay. All right, let's get down. Remember, this is an 18-month-old, okay? Let's move on to the first question. Select all that apply. Which findings indicate severe dehydration? Which findings indicate severe dehydration? Those frequent stools, okay. A, sunken fontanelle. B, sodium of 158. C, capillary refill of 4 seconds. D, potassium 4.2. Or E, absence of tears. Which finding indicates severe dehydration? So let's see here, A and E, sunken fontanelle, absence of tears. ACE, joy, Kamita, carousel. ACE, Pandy says ABCE, BCE. Christopher says all, okay. So we have our ABCE, Pandy, Joy, and okay. So the sunken fontanelle, which indicates your severe, okay, or volume loss. We have the sodium here. Is this high or low? Is the sodium high or low? 158. Is it high or low? Is this baby hyponatremic or hypernatremic? Hypernatremic. Yes. And we have the, so we know that there is a water deficit. We have the capillary refill, which is indicating poor perfusion. There's no tears, severe dehydration, and potassium is normal. So if you have this child, how would you go about with treating this potassium 3.5 to 4.5? How would you go about with treating this baby? So you have this, you go in on your shift and this baby presents to you, everybody else is busy. How you go about with treating this baby? IV fluids. What kind of IV fluids? Isotonic K. Why are you gonna give isotonic? Pandy, why are you gonna give isotonic? Baby, hypertonic. Why you wanna give the patient more why you wanna go ahead and give more sodium? Wanna just tell me so the baby hyper. In carousel, why you want to give the baby isotonic fluid? Yeah, why you want to give the baby normal saline, Christopher? Wanna just tell me that the baby's sodium is 158. Let me hear. I wanna say. Why are we gonna do the why are you gonna do the normal saline first? So hypotonic since sodium is high. Okay. Why you want to so will we, so I know some persons are given the isotonic fluid. So we know we always, whenever you're fluid depleted, you always want to go ahead and start off with your isotonic. You always want to go ahead and give your isotonic fluids, right? So even though, yes, the sodium is high, you want to go ahead and start off with your isotonic fluid. Bolus them the isotonic because they're fluid depleted. Then you can always switch over to your hypotonic solutions. All right, so you want to make sure that they are perfusing properly with your isotonic solution, and then you switch them over to the hypotonic solutions after. I give the baby ORS. So Teddy Bear, this baby, would you give this baby oral rehydration salt? Would this baby someone you'll sit down and probably try to feed? Because you start probably feeding this baby and it start leaking through the other side of the mouth. Depends. No, sir. Absence of tears. This baby bawling and there's no tears coming. No, I wouldn't want to be playing around with this baby. Heart rate in the 168. Nah. If the angel can swallow. Well, if the angel can swallow. Yeah. With a heart rate of 168, no tears, and we already identified that the sodium is so high, definitely you want to get that large bore IV and get that going. Moderate dehydration, oral won't be appropriate. Exactly. But this is severe dehydration. This one is severe. So start off, and at all times, you're going to start off with the isotonic solution. And then from there, you'll go about with switching over once, because they're fluid depleted. You always want to go ahead and do that. And then once their circulation comes back, then you can always go ahead and correct their sodium. So circulation comes first before correcting sodium. I don't understand how C shows dehydration, capillary refill. What's the normal capillary refill time? What's normal capillary refill time now? Okay. So if it is 4 seconds, it's taking too long, right? So it means that the child doesn't have much fluids on board, so it's delayed. What will happen if you try to correct the sodium too rapidly? What will happen if you try to correct the sodium too rapidly for any patient? Not necessarily only this patient, but with your patients, adult and pediatric. If you try to rapidly correct their sodium, what happens with those patients? Neuro, pandy, cerebral edema. Yes, it can lead to cerebral edema. It can lead to seizure, confusion. So that's why it's very important to make sure that you start off with making sure that their circulatory system is good. Circulation, fluid, they're perfusing well. Then you can always go ahead and address the salt. Go ahead and address the sodium later on. So you don't want it to be a case where there is too much water rushing into the brain and then causing all of that swelling. Even peripheral effusion. Camille is saying, why not A? Which finding? A is a part of the answer, Camille. A is a part of the answer. We're not missing out A. Christopher says to include volume, to increase volume. Okay. A is a part of the answer. So the answer is A, B, C, E. The potassium is fine. Okay. So, what type of dehydration this patient has? So what type of dehydration does this child have? A, isotonic, B, hypotonic, C, hypertonic, or D, SIADH? Nah, Babila. Who was the hypotonic? Rain, me go say you come late. Me go say you come later class, right? Yeah, I'm going to say you come later class. Let me pull up the slide for you. Let's go back up here. This is a scenario that we're working with. And this is the abnormal labs for the patient. Okay. So we're going to say, let's see what the answer down here is. So what type of dehydration does this child has or have? A, isotonic, B, hypotonic, C, hypertonic, or D, SIADH? C, because the packed sodium molecules and less water. Yes, nah, Babila. Hypertonic, yes, because we identified that the sodium level was 158. So we're going to say that the patient is hypertonic. Okay, hypertonic dehydration due to the increased sodium. Yes, Rain Roke. Yes. And then when we're going to treat this hypertonic dehydrated baby, we're going to start off with some little extra isotonic fluids first, because we're going to treat circulation, make sure the baby is perfusing properly. And then we can always go ahead with our hypotonic solution to deal with the salt. All right, so even though we know that this is what the patient need, we have to correct their circulation first, and then we address their salt. But we don't want to start off with hypotonic solution immediately because of the high risk for cerebral edema, seizure, coma, all of those things. So go ahead with your hypertonic, and as we said, the sodium is greater than 150. Hypertonic dehydration, water loss is greater than sodium loss. And we already identify, was it this one? No, not this one. What is the greatest immediate risk for this patient? What is the greatest immediate risk for this patient? Is it A, seizures, B, cardiac dysrhythmias, C, cerebral edema, or D, hypoglycemia? What is the greatest immediate risk for this patient? C, A. Christopher says B, cardiac dysrhythmias. C, K. Shy says seizures. Probiotics says A, B. Okay, so we only need one answer, probiotics, not a C, select all that apply. Didn't we only need one? Only one. You have to save one. Choose one. So cardiac dysrhythmias. Carousel says B. Christopher says B. Cute Nurse. Zap Music, welcome to the page. Why do you say B, Cute Nurse? Or Christopher, why do you say B, cardiac dysrhythmias? What is the greatest risk for this patient? So you have this patient who's hypernatremic, dehydrated. All right. What is the greatest risk for this patient? Seizures, cardiac dysrhythmias, cerebral edema, or hypoglycemia. Cardiac dysrhythmia, it is to potassium increase because of the high sodium. Sodium imbalance can cause seizures. Yes. Changes in conductivity. Which of the conductivity were you thinking, Christopher? I know it's cardiac, but you're saying I can't choose between A and C. How would the patient get C? How would the patient be at risk for C? So if you were supposed to choose between A and C, which one will come first? Hyponatremia is only for cerebral edema. If there was hypo. For seizure, think for seizure, think neuro. Yes, for seizure, think neuro. So if you're having a difficulty with A, and if choosing between A and C, between cerebral edema and seizures, which one would have been a priority for you with a patient that has hypernatremia? C is only if we rapidly try to fix it. Yes, that's what I was gonna go to, Camille. Just think of it. If you're rapidly gonna treat your hypernatremic patient, then C would have been a risk because of that. If you start treating with your hypotonic solution, then there's a possibility for your cerebral edema, coma, and all. Okay? But the greatest risk for your seizure patient, not your seizure patient, with your hypernatremic patients is seizure. Always think about neuro. That is always the one thing that they talk about or they teach us. So go with that one. That is your highest priority, your highest risk, and then from there. Cardiac dysrhythmia, the potassium was normal, so we don't have to be concerned about that. So even though a lot of times you might see the questions and we're saying, oh, you know, because of the risk for arrhythmias, no, this potassium is fine. So we don't have to be concerned about the cardiac dysrhythmias. As I said, cerebral edema, if we're treating rapidly, then I would say, okay, then cerebral edema. Hypoglycemia is kind of, you know, for me, is like a distractor there. So your hypernatremia, neurologic excitability, because of that, seizures occur before cerebral edema. So I will not forget this one. Okay, Christopher, good. All right, let's look at this question here. Which nursing actions are priority? Which nursing actions are priority? A, initiate IV access. B, administer isotonic fluid bolus. C, correct sodium rapidly. D, monitor neurological status. Or D, weigh child daily. So which actions are priority? A, initiate IV access. And this is a select all that apply. Initiate IV access. B, administer isotonic fluid. C, correct sodium rapidly. D, monitor neurological status. And E, weigh the child daily. So I see B, D, E, A, B, D, A, B, D, E. Okay. All right. So remember this one here. A, B, D, E, good. You do E to track fluids. Good. Yeah, and this one, you know, it says daily here. Nah, says C will cause cerebral edema. Okay. And then this one is, you know, this is daily. So it's not something that you need to do. It's not a priority now, I'm thinking. So we're going to go with our ABD, which is to initiate your IV access, because that is very important for the fluids. You're going to make sure you start with your isotonic fluid bolus. We're not going to correct any sodium rapidly because we don't want to cause any additional problem. Monitor neurological status is very, very important. Daily weight is very important, but it's not a priority right about now. Okay, it's a lot for yes, it's a lot, but it's not a priority for this patient right now. That's not a priority. When you think of priority, you're thinking about things that when you look at the pathophysiology, what are certain things that you need to do now to help with fixing that problem. So doing the daily weight is not really, you know, priority no. Not for priority. Oh, kind of a lot for priority. Okay. You're good, Trevon. Sodium, okay. Sodium, think neuro. Potassium, think cardiac. Magnesium, think respiratory. Okay, thank you for that. So let me just see if I can pin this here. So yes, yeah, so Pandy says for sodium, think neuro. Potassium, cardiac. And magnesium, think respiratory. If priority is what will kill the patient or save the patient. Yes, so one thing that you need to do to correct whatever is going on. So IV access is critical. Isotonic fluids restore perfusion. Neurochecks for seizure risk. Never correct your sodium rapidly. And daily weights are later on. And as we said, this, if you correct it rapidly, then this patient can have the cerebral edema, you know, the coma, all of those things going on. Let's go on to this one. Which order should the nurse anticipate? So is it the 0.9 normal saline bolus 20 mils per kilogram? Dextrose 5 immediately. 5% dextrose water immediately. Gradual hypotonic fluids after stabilization. Serum sodium every 2 to 4 hours. Hypertonic saline bolus. Which orders should the nurse anticipate? Select all that apply. A, the 0.9 normal saline bolus 20 mils per kg. B, dextrose 5% water immediately. C, gradual hypotonic fluids after stabilization. D, serum sodium every 2 to 4 hours. Or E, hypertonic saline bolus. C, Asante, AC, BD. Expected provider orders are gonna be what? CD. Okay, AC. ABD. AC. Okay. Which orders are you anticipating? ACD. I see a few persons with. Okay. YD if sodium is high. YD if sodium is high? You'd want to be checking on. You'd want to be checking frequently on the sodium levels to see if it's going down. It's correcting. So remember you're correcting the hypernatremia. So you want to you're correcting it. So you want to do frequent checks on it. So your ACD is going to be your answer here. So your bolus, as we say, is going to help with restoring your circulation. So your normal saline is going to help with that. Your hypotonic solutions, correct slowly. All right. So it's going to correct your sodium slowly. Frequent labs prevent cerebral edema. Dextrose 5% in water is not first. And hypertonic saline treats your hyponatremia. So your AC, your A, C, and D is what we're going to be doing. Okay. Okay, so why give normal saline? Why not lactated ringers when we will still be adding the sodium? Why do we give the sodium, the isotonic fluids? What do we know about isotonic fluids? Why do we give isotonic fluids? Why we always start off with isotonic fluids? Why do we always start off with isotonic fluids? Dehydration. Okay. What iso means, draws into cell to increase circulation first. Iso is basically the same as your blood, right? Yes, same. So you always want to go ahead with that and then you switch over. So even though, yes, we know that the sodium level is elevated, that is the one that's going to help with your circulation better. So once the patient is perfusing well, then you can always go ahead and correct the sodium. So the most important thing is circulation. Correcting circulation and then sodium. But lactated is also an isotonic solution. What's the major difference between your lactated ringers and your isotonic fluids? Your lactated ringers and your your 0.9 normal saline. Let me look up something here. Yeah, lactated ringers is better for burns, so always go with that. Isotonic. Let me see. And 0.9. I don't remember how much of this now. Lactated ringers can put potassium in the cell. Let me look at this. In my hospital, I don't work in a hospital anymore, probiotics. Yeah, it's the same as the isotonic. I'm trying to find the difference between like the normal saline and the 0.9 normal saline and the lactated ringers. What's the significant difference with it's more of the potassium and the okay. So sodium doesn't have any buffers, so it doesn't have the calcium and the potassium, while your lactated ringers does have that. Okay. So your lactate converts to bicarbonate and causes that buffering. But anyways, normal saline is what they always is the best one to use. It will rather increase it, pushing it into the cell means it will cause hypokalemia, but that's not what happens. All right, but read upon it a little bit more, and then from there. Okay. Because the lactate, Lactated ringers is usually used for your trauma burns. We know GI losses, metabolic acidosis, GI peri-op. More physiologic, helps correct acidosis, less risk of hyperchloremic acidosis. Not compatible with blood products. Calcium can cause clotting. Use caution in liver failure. Use caution in hyperkalemia. Okay, so hypovolemic. For your sodium, your 0.9 normal saline, key use is hypovolemia, shock, hyponatremia, initial fluid in DKA with blood transfusion, compatible with blood products, widely available, no potassium, safer in hyperkalemia. High chloride can worsen fluid overload, not ideal for large volume. Yeah, it just seems like it's better, a little bit more compatible, and in terms of it doesn't have the lactate in it, that's all. Yeah. LR is preferably for LR, Pandy, or normal saline. Another regular 0.9 normal saline is more preferred for your fluid resuscitation. Yeah. For liver failure, normal saline is preferred. Hyperkalemia, normal saline. Metabolic acidosis, lactated ringers. Blood transfusion, normal saline. Burns, then you have your lactated ringers. Okay. Let's move on to this question here. Which findings okay, no problem now, Babila. Okay, which findings indicate safe correction? So which findings indicate safe correction? Sodium decreases from 158 to 150 in 24 hours. B, capillary refill improves to 2 seconds. Urine output increases. The sodium drops to 138 in 6 hours. And the child becomes lethargic. So which findings indicate safe correction? A, B, C, D, or A, B, C, or B, C, D. Christopher, good. A, B, C. So sodium decreases from 158 to 50 in 24 hours. Capillary refills 2. Urine output increasing. Sodium drops to 138 in 6 hours. Or the child. We know definitely this one is out. The child becomes lethargic. So we're going to say your A, B, C. Joy. Okay. So the sodium should decrease less than 10 to 12 per day. D means there's a risk of cerebral edema. Yes, so we just have to find out what is the safest, like, you know, how much you're supposed to be dropping in terms of your sodium per hour per day. And then once we have an idea, then, you know, we should be able to answer. So sodium should be decreased less than 10 to 12 per day. D stands for dangerous here. Improved perfusion, we know, is going on with your less than 2 seconds of capillary refill. That is good. Rapid drop causes cerebral edema. Okay. Lethargy is worsening in the neurological status. So dehydration signs versus adult signs, they're totally different. When you think of pediatric and your adult, there are different signs of dehydration. Hypernatremia. How many hours before you treat hypernatremia? It's going to be within. So I guess once you're able to correct and you see improvement in terms of perfusion, so you realize that the urine output has improved, The capillary refill has improved. If you notice that the sodium is going down, well, you won't see a significant drop in the sodium, or you wouldn't see any drop in the sodium when you start off with your isotonic fluids. But once you start seeing, like, the trends, there's some correction with the vital signs, then you should be able to start treating your hypernatremia. But I don't think you're gonna be waiting 1 day before you start treating it. You just want to know that the patient is having adequate amount of urine output, and the perfusion itself is good. Within the 24 hours. So I would just, like when you have your GI patients, well, this is a GI case where they normally do the stopcock, and you have those little, we're not hanging bags of fluid, but you're doing those pushes with the IV, with the little syringes or those large bore syringes, and 2 nurses are literally pushing fluid into those dehydrated patients. So within an hour, the baby will be resuscitated well. So usually you should be able to start your treatment for your hypernatremia in a pretty decent time, because you're not hanging fluids up and be like, oh yeah, we're gonna run this over 4 hours. No. So, and we say always give your isotonic fluids first, correct your sodium slowly, and remember everything is weight-based for your children. Everything pediatric is weight-based. So if they come in and say they weigh 22 pounds, you know how to calculate that to get you to your kilograms, or if they already give you in kilograms, you know how to put it into the system. How much more slide I have? What time? 8:30? Okay. I think these were some short ones. What's this? Okay. So we have a 72-year-old male, hypertensive, type 2 diabetic, chronic stage 3 kidney disease. Patient is admitted for pneumonia. Which findings indicate that the client is at risk for septic shock? We're talking at risk for septic shock. Select all that apply. Lactated ringers, or not ringers, lactate of 3.8 millimoles per liters, blood pressure 86/52, urine of 18 mils per hour, white blood cell count of 14,200, and temperature 100.4. Which finding indicates that this client is at risk for septic shock? Select all that apply. Going to your bed? You brush it already? It smells good. Go change off into something comfy. So which finding indicates the client is at risk for septic shock? Select all that apply. Is it the lactate of 3.8, the blood pressure 86/52, urine of 18 mils per hour, white blood cell count of 14,200, or the temperature of 100.8? So B, C, D, E. Who is at risk here for septic shock? B, C, Tina, welcome, OG, Rock, Jen, how are you doing?
Where should I put this?
In the container. And then we go through. So you have a lactate. No, that is elevated. Okay. That is elevated. What do we want? What's the normal lactate reading? What is a normal lactate? Because once you know your normal levels, you should be able to answer the question. Treat each answer as a true or false. So what's the normal lactate? Less than 2? Yeah, so 0.5 to your 2. 0.5 to 2. Nice K. Okay. So usually hyperthermia, fever, So we know this is already high. The blood pressure here, how old was the patient again? I don't remember. But this is pretty low for the patient as well. So we know that this patient is headed into shock. Urine output, we already know that is low because we want it to be 30 mils per hour or greater. The white blood cell count, we can see patients with, elevated white blood cell count, but does that indicate that they're heading into shock? So no, not so specific. And then the temperature as well. So all three here are the ones that is, indicating that this client is at risk for septic shock. Jen said A, lactated ringers. Yes. Pandy says compensatory stage. Yes, they are. So elevated lactate and hypotension, oliguria is because of your tissue hypoperfusion going on, or because you have that going on. Fever and white blood cell is indicating infection and not shock. How often do we normally do our lactate? How often do you normally do your lactate, your lactic acid? How often do you normally do your lactic acid? The doctor puts the order in, there is none. We just say, oh, one less work for us, and just continue on our merry way. Is that how we do it? How often do we do our lactic? How often should you be doing lactic acid for your patients who meets the criteria for sepsis? So we get one at the initial stage when they just come in, right? Then how long after? One per shift? Oh Lord, Pandy. Ooh, that's a little bit too long. So the patient comes in at 7 o'clock and you get your first lactic acid with the cultures and everything done at 8 o'clock. When are you anticipating getting your next lactic acid? So anywhere between like 2 to 4 hours. Anywhere between 2 to 4 hours. Why we do lactic acid? What's the importance of lactic acid though? Yes, Raquel, 4 hours. What's the importance of lactic acid? To look for sepsis. Oxygenation. Yes. That usually means if it's too high, that's a red flag. If your lactic acid or your lactate is too high, that's a red flag because the patient is perfusing poorly. Patient is hypoxic, so you have to monitor the progress and if the sepsis is getting better. Yes. So if you have a patient that is unstable, you definitely want to make sure you're getting your lactic acid frequently. You want to make sure that you get your lactic acid frequently for those patients. Anything that is greater than 2 is concerning. Anything that is greater than 4 is a problem. So waiting 8 hours, if you have a patient that you're working up for sepsis, waiting 8 hours to look at the second draw for your lactic acid. By that time, the patient probably dead. You understand? So you want to go ahead and try to get it a little closer. You want to get it a little bit closer to see exactly what is going on. Yes. So let's move on to this one. What should the nurse do first? So you have this patient. What should the nurse do first? Administer antipyretics. B, obtain blood cultures. C, initiate sepsis protocol. Or D, increase oxygen flow. So you have this patient. What will you be doing first? So you have this patient that is at risk for sepsis. You already see the vitals and everything. What will you be doing first? What's your priority action? Chu or Chuno, welcome. C, Dainty says D, increase oxygen flow. Let me go back up to the top here. What will the nurse do first? And then this is a patient, 72-year-old, hypertensive, type 2 diabetic, chronic kidney disease, stage 3, admitted for pneumonia. Patient is at risk for sepsis with all of these labs. Okay, lactate 3.8, 86/52, blood pressure, urine output of 18, white blood cell count 14,200, and temperature of 100.4. So what should the nurse do first? A, administer antipyretics. B, obtain blood culture. C, initiate sepsis protocol. Or D, increase oxygen flow. What will you do first? I see C, B, B, B. Okay, let me see. All right, so Dainty says D, increase oxygen flow. Why would you increase oxygen flow, Dainty? Why would you increase oxygen flow? And then I see B, initiate sepsis protocol. C, since it will mean increase in perfusion. B says blood cultures before antibiotics. Okay. I always do A, administer antipyretics. Okay, Billy Ray, welcome, welcome. So what will the nurse do first? You're gonna go ahead and initiate your sepsis protocol. Okay. So your next generational NCLEX question, they prioritize your system level. So time sensitive action. Everything in this sepsis protocol is gonna be time sensitive. From obtaining blood cultures, the lactic acid, the antibiotics, everything is going to be time sensitive. So it's very, very important for you to identify your patients with sepsis and initiate the protocol and get those going. Your protocol is going to include your antibiotics, your labs, and your fluids. All right. So you have your patient here. You already initiate your protocol. So you initiate your protocol here. What will you be doing next? So you are there, you're the only nurse, the other nurse is on break and she's taking too long because she's watching me live. Yeah, so you have this patient now. What are you gonna be doing? You initiate the sepsis protocol, you're alone. What's next? What are you gonna be doing? You're smoking, Christopher. Next, B, okay. Obtain blood cultures. So Sue says B. Obtain blood cultures. Okay. IV fluids. All right, go ahead and tell me about your... I believe probably will be. So Joy says, why not B? So Joy, the first thing you want to do is you identify your patient with sepsis. You want to go ahead and initiate a sepsis protocol. So I want to find out, we're going to just talk a little bit about what we're doing. So you initiate a sepsis protocol. You're alone on the floor right now because everybody else is watching my live stream. So you're there, you're running the show. How are you gonna go about with taking care of this patient? So we know we're gonna give, we're gonna get the blood. So it's a sepsis protocol include blood. So it's a administer. Okay. Yeah, so we're gonna get the blood. Are we gonna get 1 blood, 2 blood cultures? Or are we gonna wait 30 minutes, 40 minutes after the first blood antibiotic is completed, then we give this, then we get the second blood culture? How we do it? I want you guys to just walk me through it, what you would do. So you have this patient is lying there. You're going to be getting your blood culture. How you get your blood culture? How do you get your blood cultures? Set an set up IV access. Yes, so set up your IV access. You always try to get 2 large bore if you're able to. If you can't get it, you just get 1. Clean the sites. Get your cultures. You get your first one. You can wait your 15 minutes. Then get your second one. If the patient has really good veins, collect from 2 different sides, but the best thing is to get from 2 different sites. I always go for the ACs. Always go for the ACs, because then 15 minutes after they get the first antibiotic, you can always go on the second line, you know, IV access to start the second antibiotic. Get those medications going. So collect from 2 different sites. Good. And label them. So you label the bottle. You take 2 sets of blood using aseptic technique. Good, Zara. And you label the bottles. And I always put the site where I get it from. So if it is the left AC, I write on the bottle left AC, the time, and the date. And if it's the right AC, I do the same thing. If it's the wrist, I put the same thing on it. If it's a case where I already gave the antibiotic because it was a hard stick, because the patient vein was too flat, I go ahead and just document on it that vancomycin was already given. So that way, at least they know that vancomycin is in the blood, in the bottle. Okay? So just write it on it so at least the lab can be aware of what is on board. Take the temperature too. Yeah, you're going to go ahead and take the temperature. So you get your 2 blood cultures, but never, you know, delay giving your antibiotics because you're having a difficult time with obtaining your blood cultures. The patient needs those antibiotics. So if you can't get the blood, then always go ahead with your antibiotics. You can always go back to it. And one thing I always do is, if you have a patient that comes in with sepsis, do you always get a urine with those patients? Do you always get a urine test with those patients? Do you try to get a urine sample for those patients? Do you just bring a urine cup and say, hey, can you just pee in this bottle? Yes, you do? Nice. Large bore catheter reduces hemolysis. Yes, Christopher, nice. Yes, so it's always nice to go ahead and just get everything before you start antibiotic. When my patients come in, like them going to them bird suit, you understand? And in and out catheter, I get them urine, I get their 2 large bore IV, get their blood cultures, and I get their 2 antibiotics going in, and we're done. You understand? So try and get everything that you can get at the initial, and then you start your antibiotics. So at least you get better results for your patient. I remember your lactic acid as well. If you don't see the protocol with the lactic acid, ask the doctor to put it in. And none of them not going to be like, oh, no, we don't want it. Trust me, they're going to want it. They're going to be wanting it. So you can always just talk to them, let them know that it wasn't added, and they'll just add it. But don't be one of those nurses that you get everything and you send it off, and then you know, 2 hours later, the doctor is asking, so where's the lactic acid? And you never say anything to the doctor, and everybody running around now looking for, you know, the results. And it's like a big delay. Get it because you know that it's a part of the protocol. Okay, let's go on to this question here. So the acid-base imbalance we have here, ABG. The pH is 7.29, the PaCO2 is 48, the bicarbonate is 21. What is your interpretation here for this? What's your interpretation here? Respiratory acidosis, mixed acidosis, metabolic acidosis, or fully compensated acidosis? Metabolic acidosis, Kai. Lil Blink says A, respiratory acidosis. is Chun says metabolic Su A. Okay. Anybody else? Anyone on YT says anything? What imbalance do you see there? What kind of imbalance? Partial compensation. It's uncompensated respiratory acidosis. Nah, Babila says. A, the lungs is a problem. It's not compensated either. The bicarb would be higher. What kind of acid-base imbalance are we seeing there? What's a normal pH? What's a normal pH? Okay, Zara, why do you say it's B? Why you say it's B? So Zara said it's mixed. Okay, so the normal pH pH is 7.35 to 7.45. Good. I'll soon come back to you, Zara. And Lily Blink. PaCO2. What's the normal PaCO2? What's the normal PaCO2? 35 to 45. Okay. And then what's the normal bicarbonate? (22 to 26). Good. So 7.29 means anemic. PaCO2 is high, so respiratory acidosis. Okay, so the interpretation we have here is your mixed acidosis, because you have both your CO2 and your bicarbonate is abnormal. So the two systems shucks. That was supposed to be it. Are abnormal, so the two systems are failing here, right? So you have your mixed acidosis going on. So remember, this is a perfect word for your, so who is this? Red File says repeat the ABG. Yeah, that's what we will do in the real world that we're living in right now. In NCLEX world, in NCLEX world, even if it is off by 1 point, it's still abnormal. So it will be considered to be an abnormal reading. So the 21 here is still outside of your 22. So your answer is going to be your mixed acidosis, because your CO2 and your bicarbonate is abnormal, so both systems are failing. Okay. PCO2 is acidic and bicarb is also acidic, making it the mix. Bicarbonate is overcompensating. Yes. So when we have the bicarbonate here, what system is failing when you have the bicarbonate? What system is this? HCO3 represent what system? What system? What organ is giving problem? The renal, kidney, yes. And then your PaCO2 is what system? Your lungs. Good. Respiratory. Bicarbonate, because the kidneys are releasing too much bicarb. Shy. Good. So whenever you see one system, if the CO2, PaCO2 is a problem, then you know the compensating system is gonna be your kidneys. So the respiratory system here is giving problem. The compensatory system is gonna be your renal system here. If this is giving problem, you know the compensatory system is gonna be your CO2, your respiratory. Okay. A client has a potassium of 6.9. We know that the reading we said earlier would have been 3.5 to 5. With peak T waves, what is the priority intervention? A, sodium polystyrene, sulfonate, B, insulin with dextrose, C, hemodialysis, or D, IV calcium gluconate. You have a patient that has potassium 6.9 with peak T wave. What is the priority intervention for this patient? So K says D, IV calcium gluconate. Asante says D, D, D. Sue says C, hemodialysis. Okay. And if you have this patient, potassium 6.9, peak T wave, we know that this patient is hyperkalemic. The priority for this patient who has hyperkalemia and showing peak T wave on their EKG is because of their arrhythmias, okay? So want to make sure their heart, that's priority for that patient, okay? So what does calcium do for that patient? Insulin solves the hyperkalemia and dextrose is to solve the hypoglycemia. Okay. So the calcium is to calm the heart, and you want to calm the heart before you drop the potassium. Exactly. So protection for the heart. Stabilize the heart. So calcium stabilizes your cardiac membranes, and we say that the insulin is going to help with solving that potassium there. Sodium polystyrene, is that something that you would consider for a patient with a potassium of 6.9 and having peak T wave? Is that something that you would consider to be like priority for that patient? No? Okay. Because it's an oral medication. It's an oral medication, so it's not going to be something that is going to work right now. It's not going to be effective. Yes, but I would do that after the insulin to permanently remove the potassium. Yeah, but in the NCLEX world, because you'll still see us give it, we'll give it, but in the NCLEX world, it's not something that is a priority because it's an oral medication. It's not going to be working until what? It passed through the gut, and how long it take before? Probably like 4 hours. It start taking full effect. So you wouldn't want to go ahead and say that is a priority intervention, but you'll see where we give nebulization treatment, and it does help with lowering potassium, but is it a priority intervention? So if you see it pop up in, like, you know, you select all that apply, I would be very, very careful with the oral medication whenever you see, especially they're saying that the patient having changes on their EKG already. And if it says priority intervention. So I will probably choose that one for a priority intervention if I have it in a select all that apply. And then hemodialysis. I know someone had chosen hemodialysis earlier. When would we go to hemodialysis? Hemodialysis is like last resort. Yeah, 4 hours is too long. Hemodialysis is like, you know, for your end-stage renal disease patients. So definitely you want to get them on that machine to clear out their system. So your end-stage renal, when it's the last thing you can do for them, then definitely you want to get them over there. Or get it to them. Which finding indicates hyperkalemic or hyperkalemia complications? Muscle weakness, bradycardia, narrow QRS, ventricular dysrhythmias, or tingling sensations. So first do is D, then B. D. Yeah, so you're gonna do your D, your calcium, and then you're gonna do your insulin, so you can get those potassium out of the cell, into the cell. And then you can always think about your, you know, oral medication if needed. Which finding indicates hyperkalemia complications? A. Muscle weakness. B. Bradycardia. C. Narrow QRS. D. Ventricular dysrhythmias. E. Tingling sensations. Which finding indicates Which finding indicates high potassium complication? That's how we're going to say it. Which finding indicates high potassium complication? Is it A. Muscle weakness. B. Bradycardia. C. Narrow QRS complexes. D. Ventricular dysrhythmias. Or E. Tingling sensation. Rhea says C and D. Chun says A, C, D, E. A, C, D, E. Okay, Joy says D. C and D. Pustain, sugarcane, welcome, welcome, welcome. B, C. Okay, who is that? Asante says B, C, and D. Joanna says A, C, D. So A, B, D. So your muscle weakness, remember your high potassium affects your muscles, your cardiac conduction system. Also, so you're going to have your bradycardia, and you're also going to have your ventricular dysrhythmias because of that. So the narrow QRS is not something that is consistent with your hyperkalemia, and the tingling sensation is not. A, B, D, because high potassium, everything is high except the heart rate and the urine output. Yes, shy. Good. Which client should the nurse see first? The dialysis patient with a potassium of 6.6, COPD with SpO2 of 90%, post-op patient with pain out of 9 out of 10, or D, the client awaiting discharge instructions. Who will you see first? A for sure. A for sure. A, good. Your potassium patient, because always think of your cardiac patients first. The COPD, this oxygen saturation is normal for them. We want it to be anywhere between 88 and 92%. So this is not a priority. The post-op patient is pain. Yeah, 9 out of 10 will see. Client awaiting discharge teaching definitely can wait a little bit longer. So go ahead and sort out your dialysis patient. Then you can run over to your post-op patient, and then from there, you know, the COPD can hang on. I will probably just do the discharge patient, free up the room, and then head over to my COPD patient. As long as they're in the range, there's nothing significant. Unless he's complaining of something else, then definitely. So hyperkalemic patient because of the risk for your cardiac arrest. You have a client with an inferior MI who has a blood pressure of 82/42. Which medication should be held? Your aspirin, morphine, nitroglycerin, or your heparin? So you have a patient with inferior MI. What do we know about inferior MI? So which of the medications should be held? K says B. She's going to hold off on the morphine. She's going to hold off on the aspirin. And then Pustain is saying, going to hold off on possibly the nitroglycerin. COPD, what is the normal oxygen level we can put them on when they complain of shortness? You don't want to pass. I think it's what, 3, 4? Let me double check something for their oxygen. I think it's 4. You don't want to pass with them. So the SEPSIS is supposed to be anywhere between your 88. Okay, so 1 to 2. I'm gonna kill them off. So which of these medication will you be holding? Your nitroglycerin. It causes vasodilation. Okay. It will lower more blood pressure. Okay. So it causes vasodilation, but morphine vasodilate too. Yes. So what is so special about the nitroglycerin? Why you want to hold off on it because of the vasodilation in inferior MI? What do we know about inferior MI? What is happening there? So we know it lowers, nitroglycerin lowers the blood pressure. Okay. They can get life-threatening hypotension. Good. What we know about inferior MIs and preload? Because it causes hypertension and decreases output. It affects the muscles. That's like morphine helps decrease. Okay, so here it says an inferior MI usually involves the right coronary artery. That artery often supplies the right ventricle, so preload becomes a big deal. The right ventricle is weak. It can't pump blood forward effectively, so it becomes preload dependent. So your inferior MIs are preload dependent. So if you go ahead and give the nitroglycerin, you're going to have the patient becoming hypotensive, severely hypotensive because of that. So you want to hold off on your nitroglycerin. So it's very, very important. You see why it's very important for you to get an EKG before you decide to go and throw a nitroglycerin under the tongue? Supplied by the right RCA. Yes, answer Hanson. It's very, very important for you to go ahead and get your EKG. Get your EKG before you go ahead and throw that nitroglycerin under the tongue. So even though the doctor, says that yes, because some places you might see where there is an order set and the 3 little tiny tablet is ordered as a part of the order set standing order. So we just feel as though, yes, we do the EKG, so we must just go ahead and throw the little tablet underneath and they say, oh, you can give 3, 1 behind each other because the doctor is a little bit busy. No, wait until somebody read the EKG. Because the last thing you want is for the patient to have an inferior MI and you're already there on, number 2 on the nitroglycerin, and the doctor is going to be like, well, yeah, hold the nitroglycerin. And the patient already absorbed 2. So you're going to have to figure out how to correct that severe hypotension that is going on because of those 2 nitroglycerin. All right. So make sure you get a reading first on your EKG, then you decide to go on to your nitroglycerin. So MI often involves the right ventricles. Preload is very preload dependent. So your nitroglycerin relaxes your veins, causing less blood to your heart. And that decreases your preload, which leads to your heart working less. So in essence, nitroglycerin decreases preload. Because I know a lot of times, sometimes we're doing things and we don't really know the rationale behind why we're doing certain things. So it's always nice to know, because then you'll be able to put a pause on some things that we're doing. A head injury patient shows bradycardia, hypertension, and irregular respirations. What is this called? Autonomic dysreflexia, Cushing's triad, neurogenic shock, or increased MAP? B for sure for increased intracranial pressure. Okay. Good. BBB. Where do we normally see autonomic dysreflexia? What patients do we normally see this commonly with? Oh, Nike says C, neurogenic shock. Spinal, anything above T6 and blood pressure would be very high and they would have headache. Neurological issues with spinal issues. Okay, yes. And spinal cord injury, T6 and up. Posting, sugarcane, good. Yes. And what are some signs and symptoms for a patient with autonomic dysreflexia? What are some signs and symptoms for these patients? Decreased urine output because their bladder is distended. Flushing of the skin, headache, hypertension, abdominal distension, full bladder, yes. So what is one thing they always want to do for your patient with your autonomic dysreflexia? What is one priority action that a lot of times they will say, hey, go ahead and do this? What is that one thing you want to go ahead and do for that patient? With your patient with autonomic dysreflexia, catheter, get that UCath, yes. Elevate the head. It's a catheter. Definitely want to go ahead and insert that catheter. Find out if the bladder is distended, and from there, can always do other, deal with the blood pressure and everything else. But most of the time, the bladder is the problem. The sweating, the bladder is the problem, and then from there, usually that kind of corrects certain things. What we know about neurogenic shock? What do we know about neurogenic shock? Elevate the head of the bed, bladder, and check for fecal impaction. Yes, nah, ballet. The same hypotension and tachycardia. With tachycardia or without tachycardia? Are they tachycardic? Yes, I'm gonna say green car, and some other stuff there. Yeah. Are they hypotensive and tachycardic, or hypotensive and no tachycardia? Yeah, they're bradycardic. Good. So they're hypotensive, bradycardic, a lot of times hypothermic. Good. All right, nice. What's the normal map we're looking for? What's a normal map? What's a normal map you want for your patient? What's a normal map? Normal 20. 65. Anything greater than 65. Ting-a-ling, yes. Anything above 65 is what your aim is. So 70 to 100 is basically like textbook normal, but when you have those really, really sick patients, we're always looking for anything greater than 65. 65 for your MAP, your mean arterial pressure. Okay. Okay, so we say that that one is Cushing's triad, the bradycardia, hypertension, and the irregular respirations. ICP. Figure more or less you were thinking about that along that line. Post sugarcane says 65. Okay, good. Let's move on to this question. What's the nurse's priority action? A, suction the airway. B, elevate the head of the bed. C, administer sedatives. Or D, perform neuro exam. What's the nurse's priority action here? What's the nurse's priority action for this patient? B, elevate the head of the bed to promote venous drainage from the brain. You don't suction because it increases the pressure, yes. Want to hold off on your suction. Your sedatives, is that very important for this patient? Would you sedate this patient? Would you sedate this patient? Administer sedatives? No? Why? Why not? Okay, the blood pressure is already low. Depress it further. He's bradycardic. Nervous system, only when there is seizure he'll go ahead and give something. Okay, and then definitely you do your neuro exam. So non-invasive intracranial pressure reduction first. Suctioning increases your intracranial pressure, so always go with you always try to avoid that. Okay, avoid that. If you're supposed to be suctioning any patient at all, how do you normally go about with suctioning? What's the procedure in terms of the time period? How long do you normally stay in while you're suctioning? What's the time period you're looking at when you're suctioning? How many seconds should you be staying inside the patient's mouth or airway? Shai says you hyperoxygenate them first. It only suction for 10 to 15 seconds. Less than 10 seconds. Yeah, I know the less than 10 seconds. The 15 to 20 is a little bit long. A little bit long for the 20 seconds there. Yeah, but you definitely want to hyperoxygenate them, and then you go ahead and suction, because you know when you suction you're going to rob them of their little oxygen that you already hyperoxygenate them with. So you don't want to stay too long. Good. Which finding differentiates HHS from DKA? What's HHS? Which finding differentiates HHS from DKA? Go ahead and just type out HHS. What's that? What's HHS? What's HHS? Thank you guys for tuning in. If you haven't followed us yet or subscribed us yet, remember to go ahead and do that. They can't remember. I remember DKA. That's why I ask you, Chantel. That's why I ask you. Yes. What's HHS? C. You know, says C. Everybody else says C. Severe life threat. Severe life threatening diabetes. Okay. Let me see who is gonna save the day. Hyperosmolar hyperglycemia. Joy. Thank you for that. Shy. Thank you for that. Hyperosmolar hyperglycemic state. So which finding differentiates HHS from your DKA? A, ketones present. B, pH of 7.30 or less than 7.30. Glucose greater than 800, or D, your cosmol respirations. So which of them differentiate? I see that everybody was saying C, greater than 800. 800 for your glucose. Okay. So K says A, ketones present. Anita says A, ketones present. E says no ketones in HHS, just DKA. So with your HHS, you have your glucose. So your glucose is usually very, very high, greater than 800. Okay, so we know that in DKA, you have your ketones present. For your pH, it's usually less than 7.30. And we know that for your DKA, they have the cosmol respiration. Why do they have the cosmol respiration? Why do we have the cosmol respiration for your DKA patients? Or not necessarily, let's not say DKA. Why do we have cosmol respiration? Compensating. Okay. So they're compensating, so they're blowing off that acid, and so you tend to have cosmol respiration. And we know that is consistent with your DKA patient because of the ketones. Yes. So HHS, is this something that is, so we know that metabolic acidosis. So which of these two, so we know both of them are medical emergency. Which of them is, severe? Both of them are severe, but which of them is like very life-threatening? Which of them are you gonna be very, very worried about? Okay, so I see DKA, Mumbi says HHS, and the green car. Okay, Mumbi and the green car, why are you saying HHS? Why are you concerned about your HHS versus and not your DKA? Becky says, Becky Splash, tell them to. Why is HHS more serious than your DKA? Why kills more people? Yeah, why kills more people faster? Dehydration. But both of them with the dehydration, but with their HHS, it's something that happens like slowly. Okay, it happens slowly, and so there is usually no early warning. There's no early warning, so by the time the patient seek medical treatment, it's like the end of the road for them. versus with your DKA, usually a day or two, they start having all of those symptoms, so you can always aggressively get treatment going for them. So your DKA is more rapid, and then your HHS is slower. So in terms of with your dehydration, your HHS patients are gonna be so dehydrated by the time they get to you or they get to the hospital, and so that is why the mortality rate is so high with them. HHS need isotonic and hypotonic fluids. DKA is more rapid onset with no ketones will raise osmolarity of blood without urgency with HHS. And Sir Hansen, yes. So that's just the problem with both of them. So both of them are really bad, but in terms of mortality, your HHS is a problem. DKA is more serious because of ketones and everything that comes with it. Which one is priority? Your DKA. Your answer here though is C. The answer here is C. But your priority between these two patients is gonna be your DKA. Because as I said, this patient is gonna start showing you more symptoms. Because when the patient presents in front of you, this patient is gonna be more symptomatic, or depending on the lab findings, you're gonna have more things to work with for this patient here versus this patient that might take weeks before they're gonna be showing any signs and symptoms, or the labs are gonna be off. So your priority patient is the one that is gonna be symptomatic, or you have your lab findings for. All right, let's move on to this question. So insulin and potassium. Yes, if the potassium is abnormal. We correct the potassium if the potassium is abnormal. Signs of hypoglycemia include diaphoresis, confusion, fruity breath, tremors, polyuria. What are the signs of hypoglycemia? Select all that apply. What are the signs of hypoglycemia? A, B, D, diaphoresis, confusion, tremors. I see my Naira Scrubby says A, C, E. So diaphoresis, fruity breath, and polyuria. I see A, B, D, E, A, B, D, E. What are the signs of polyuria, of hypoglycemia? A, B, D, A, B, D. Okay. So you have your diaphoresis, your confusion, and your tremors. Your fruity breath. When you have a patient that is hypoglycemic, do we always have them having the fruity breath? No. And the polyuria? No. So the fruity breath is there for your DKA, okay? And that is more when you're hyper. And then your polyuria, classic diabetes, but not necessarily say when your patient is hypoglycemic. Okay, so your diaphoretic patient, they're confused, they're having those tremors. BDA. Unique, welcome. Conqueror, welcome. Okay, let's go on to this one. A postpartum patient has heavy bleeding, boggy uterus, and deviated fundus. What are you thinking? What's going on with this patient? Postpartum patient has heavy bleeding, boggy uterus, and deviated fundus. What are you thinking? What's the diagnosis? CBBB, CCC. Okay. What's the diagnosis for this patient? What's going on? Retained tissues. Okay. You have a postpartum patient who is having heavy bleeding. Postpartum patient having heavy bleeding, buggy uterus, and deviated fundus. What are you thinking with this patient? Patient having uterine atony. Brown says uterine atony. Okay. So what should the nurse do first? So uterine rupture. Let's see, eclampsia. So massage the fundus, administer oxytocin, massage the fundus, assist the void, start IV fluid. What should the nurse do first? Because it's deviated, I would do C. Yes, definitely retain tissue placenta, but deviated means it's to the side, so I would say C. B, massage the fundus. Just one answer, massage, then assess. Okay, so this patient is having heavy bleeding, buggy uterus, deviated fundus, postpartum. Go ahead and assist the patient to void. Why are you assisting the patient to void? Why are you assisting the patient to void? B, and then you might need to catheterize. Why are you gonna assist the patient to void? Because the full bladder is preventing the uterus from contracting. Okay. So it's deviated to the side. So you want the bladder to be empty. So you can go ahead now and massage the fundus to get this problem here fixed. So you can get this problem here fixed. Because if this uterus continues to be boggy and you continue having the heavy bleeding, what can be happening with this patient? So if you're there massaging this patient fundus, but the patient is still having the heavy bleeding, the patient is going to be at risk for what? But if they're heavy bleeding, wouldn't you do that first? Patient is going to be at risk for shock. Yeah, postpartum hemorrhage. Oh, that makes sense. Big bladder in the, yes. So you want to make sure that you assist them to avoid, empty the bladder first. And then once we get that out of the way, we know that there is nothing like a ball there that is preventing the uterus from contracting, right? So once we get that out of the way, then you can go now and safely massage the fundus. If we know that the patient is still bleeding heavy while we're there and the uterus is boggy, then we know we have a problem. Really, you will just tell me to massage first, or am I the problem? So which other answer, which other option you had there? It depends on what options you have there. So you want to go ahead and assist the patient to void. If this is not there, then definitely you want to go ahead and massage the fundus. So depending on what answers, the options you have. So remember, you always want to start with, like, you know, C is for sure first. Yes, you always want to start off with anything that is like, you know, true, I'm going to look back at that later. Okay. So go ahead and start with your little, you know, nursing or whatever you can do. So assist the patient to void and then you massage. But once you're able to get the bladder empty, then you'll be able to massage and get that fundus down a little bit. Why void? Because if the bladder is full, it's going to be difficult for you to actually get that uterus contracted. So the boggy uterus that we're trying to fix here, that is contributing to all of this heavy bleeding, if the patient's bladder is still enlarged because she has too much urine, then it's gonna cause displacement of the uterus, and then this uterus is not gonna be able to contract properly. So you just buggy massage uterus, buggy displaced void. Ask them to walk if deviated bladder. Yeah, and it depends on their vitals as well. So you have to just make sure you look at the, you know, what they present with the scenario, and then from there, the massage. Feel the priority for voiding, we are putting in catheter. It depends. It depends. You can catheterize a patient. You can catheterize a patient, or you can put the patient on a bedpan, bedside commode, whatever. If the patient is stable enough. You're only doing that if the patient is stable enough. Fill question prior to the massage. Answer. No, what? Oh, yes. Yes, Echo. If the question was a priority question, thank you for that. If the question is a priority question, then definitely massaging the fundus is what you definitely want to go ahead and do. But this is a first question. So it says, what should the nurse do first? So definitely you want to go ahead and assist to void. If it's a priority, remember we said that priority is anything that is going to help with solving the underlying problem, the pathophysiology of the problem. So we know that this patient is having the heavy bleeding because of this buggy uterus. So we need to get this fixed. And the one thing that we can do to get that going is to start massaging the fundus. So that is going to be priority. So if it was a priority question, what should the nurse do? You would go ahead and massage the fundus. What should the nurse do first is assist to void. Elevate the head of the bed. Stop, you know, things like those. Less invasive things. Okay, good. So we said the full bladder prevents uterine contraction, so you want to get that out of the way for the patient. Which finding suggests placental abruption? Which finding suggests placental abruption? Painless, bright red bleeding, dark bleeding with pain, soft uterus, fetal tachycardia. Which finding suggests placental abruption? B. Good. Dark bleeding with pain. Okay. Painless, bright bleeding. What is this? What condition is this? Painless, bright bleeding. Painless, bright bleeding is what? Placenta previa. Okay, good. Between placenta previa and your abruption, which one is your highest risk patient? Your abruption or your previa? So if you have those two patients, which of them are your high risk patient? User 252 says your abruption. Okay. Okay. A18, why is abruption more serious than your previa? Placenta abruption, they need to get to the OR. Can lead to fetal tachycardia, I believe. Answer, yes. It's life-threatening. Okay. All right, so we know bleeding. It has disconnected from the uterine wall. The fetus and the mother at risk, good. Hemorrhage. We have like fetal demise, hypoxia. So all of that. Just think of the word abrupt. Fetal, placental abruption. Everything just suddenly get cut off. Lead to shock. So yes. So that one is going to be, you know, your very, very high risk patient. Good. Yes, Anzic Blue. Okay. So we said the dark bleeding with a pain is the one that is more suggestive of your placental abruption, and the bright painless bleeding is your previa. Well, let's see this one. A client says to you, I've been saving my pills. What's your best response? Why would you do that? Are you planning to harm yourself? Let's talk about coping skills. Many people feel this way. What's your best response to this patient? I've been saving my pills. Are you planning to harm yourself? Mansa says C. Let's talk about coping skills. Okay. BBB. Kinmi says Kiranjit. So always go ahead and try to explore, find out what is going on, ask direct question, all right? Find out if they're planning on harming themselves, anybody else, things like those. You can always talk about this, okay? You can always talk about coping skills, but you want to find out. They're in front of you. Go ahead and find out what are their plans. What's your plan? Which client can legally leave the unit? So you have these patients with you. Which patient can legally leave that unit? Is it the patient that is involuntary psych admission, the client on a medical hold, the voluntary psych admission, or the client on the court order? Let's see. Miss Independent says involuntary psych admission. Look at the word involuntary, not voluntary. Against his will or her will. First and foremost, you would ask the client why, and then the following would come after to clarify. Exactly, Queen Tash. Okay, so which client can legally leave the unit? C. Okay, the voluntary psych admission. So sometimes they say, well, I voluntarily came in so I can leave. Yeah, man, let them just sign the paper and go. I'm going to argue with them. But the involuntary ones, definitely you get other people on board. The medical hold, can't send them go nowhere. And the court order, we can't send them out. Okay, but the ones that voluntarily come in, they know that they need help and they feel as though they want to leave right now. And they say, oh yeah, I'm going to the bank, I'll be back in a week or two. Definitely send them on their merry way. They'll be back. A ventilated patient has a high pressure alarm and absent breath sound on one side. What's your diagnosis? What's going on with this patient? So you have a patient that is on the vent and you'll notice that the high pressure alarm is on and absent breath sound on one side. What is going on with this patient? What are you thinking? So you go over there and assess the patient. What are you thinking? I'm going to continue watch my TikTok. What are you going to be doing? Suction the airway. Okay. Kyla says D. Reposition the patient. Okay. All right. Answer says pneumothorax. Dr. Will Lacoste. C says prepare for chest tube. Okay, Doctor with Will Lacoste. Pneumothorax, echo, nice. Echo speed cubes, yes. Definitely. So look at it. So you have a patient that is on a ventilator and the high pressure alarm, even if you don't know what high pressure alarm is all about, all right. Absent breath sound on one side. What is ringing out at us? I see A and D, suction airway. Okay, so you have this space. So you're suctioning airway. My mind was saying D, but I said A. Okay, tracheal deviation. Well, I never really give anything else with the tracheal deviation. It just says absent breath sounds on one side. So what is jumping out at us is a pneumothorax, right? Never really say tension, but we know that there is a pneumothorax. It's Sasha. The suction is up against something. Okay. Suction the airway. All right. So when so whatever secretion went in, did it go on one side of the lungs? Is that something like that? Is that how we're thinking? Like the secretion just go one side, go to the left side, and just hang out over there. So the right side is, you know, where it go? The suction is up against something. I need to. So you have absent breath sound on one side. One side is not getting any air. Absent breath sound, something occluding. Is either the secretion? Something is preventing air from going over one side. So you're going to suction the airway. You still listen. Something is still not, you know, you're still not hearing any breath sound. Okay, so you reposition the patient. There is still absent breath sound on one side. So absent breath sound on one side means one lung not working, if you understand correctly. So D. Okay. I will say A. What's the diagnosis here? What's the diagnosis for this patient? So you have this patient working with, you have a ventilated patient. You're always working with some what you call it, differential diagnosis. What are you working in terms of with the diagnosis? So you have a patient here, ventilated patient. The alarm is going off. Let's just say we don't know anything about the alarms, but we hear absent breath sounds on one side, or we evaluate the patient and we get absent breath sounds on one side. Pneumothorax, Becky splash. Good. Spontaneous pneumothorax. Pneumothorax, you need to do a needle decompression, chest tube. Shy, nice. So the absent breath sounds is the giveaway there. So the priority action for this patient is definitely going to be your chest tube. You want to prepare your chest tube. Right? So your chest tube is going to be your priority. If, let's just say, we had deviated, let me just put in deviated a deviated trachea, what would have been your priority there? What would have been your priority there? So the priority for this patient, if you had deviated trachea there, what would have been the priority there? Let me just put in this answer. Let me just put this. Needle decompression. You would have been, yeah, needle decompression. If you're supposed to choose between the two of them, prepare for chest tube, needle decompression. This one is going to be your best option, right? Because you're thinking about a tension pneumothorax. So you definitely want to go ahead and get the needle decompression going. Second intercostal. How about if the question is first? So let's go back to, let me just delete this. So the one thing that you need for your tension pneumothorax would have been your needle decompression to get rid of that pressure there. For this question here, that doesn't suggest that it's a tension pneumothorax. It just says absent breath sounds on one side. You want to go ahead and prepare for your chest tube. That's your priority action here. If you were supposed to say first, if you're looking at first, thinking about like non-nursing. Non-nursing action, suction airway. I don't really see why I would probably suction the airway here based on this. Lower tidal volume, reposition patient. I would still probably keep this one. Prepare the chest tube as priority action for my patient, because that is what is gonna fix this. If these were the same option and it was just a first, that would have still been my option. I don't know much about, you know, the pressure alarms in ICU. So as I say, I would be going with this part. This is a part of the question that I'm running with. But as I say, when it comes on to priority, what is that one thing that you need to do to help with correcting the problem? So we know that if it's a tension pneumothorax, we need to put in a needle to help with getting that pressure out, or getting that that positive pressure, get rid of that positive pressure. If it's just a chest, you're thinking about pneumothorax, we need a chest tube, right? Just like, so for example, you have your hypoglycemic patient. What is it that the patient needs? The patient needs little glucose. So things like those, that's a priority. Hope that makes sense. Okay, let's move on to this question here. Which ABG matches respiratory acidosis? Which ABG matches respiratory acidosis here? Betty Splash says A, pH 7.28, CO2 of 55, 7.48, CO2 30, pH 7.36, bicarb 18, or pH of 7.52, bicarb of 30. Okay, so C is A. Okay, so we said the normal pH should have been, so we're looking for respiratory acidosis, right? So we're looking for pH of 7.35 to 7.45, so anything below 7.35. And this is above, this is above, this is above, so this is gonna be it, A. Bicarb 35 to 45, good. So we know that CO2 is the one that has to do with your respiratory system, and your bicarb has to do with your metabolic or your kidney or renal. So once you're able to identify your normal values, then you'll be able to, you know, determine your respiratory versus your acidosis. Oh, okay. Then the final priority question we have here. Which task can be delegated to your unlicensed assisted personnel? Is it A, assess the lung sounds, B, teach insulin injection, C, obtain finger stick glucose, or D, evaluate for pain? C, obtain finger stick glucose. Yeah, everybody can do that, right? Patients do it at home. So once you know what UAP means, you know the roles, different roles, then definitely you'll be able to decide on that. And remember, your RN, your registered nurses can do everything that has to do with your assessment, teaching, evaluating, everything that you eat. Yes, never give, eat. Yes, never give anything that you eat. Evaluate, assess, teach, and once you're able to do that, then you can delegate the remainder. So C is your answer. Which lab requires immediate follow-up? The sodium of 130, hemoglobin of 10.8, potassium 6.4, or your calcium of 8.2. And we see that one coming. C. Good. Your potassium 6.4, but hemoglobin are low too. And the NCLEX world, hemoglobin is low, so I don't go and look at the hemoglobin. Why all the time you have to choose potassium? After that? Okay, nice. So immediate, and then always think of, you know, as we say, potassium cardiac, more life-threatening, so address that one first, and you can always address everything else. Because the patient can go into VFib. Arrhythmias. Good. Okay. Which outcome best shows effective shock management? Which outcome best shows effective shock management? You have to choose one. Only one. Okay? Heart rate decreases. The MAP is greater than 65 millimeters of mercury, SpO2 of 95%, and the white blood cell count is normal. So which outcome best shows effective shock management? Anita says A, questioning that. Supertime says A. Which outcome best shows effective shock management? And Zeke says B. It's Sasha says B. Answer Ansan says B. Dainty B. Don Ven says B. Okay. Christelle says A. Joy Otio backup says A. All right, so I go down the road down there, so, and when I run down the road, my heart rate went up to 120. I walk back up the road, and now my heart rate is 60. B means good cerebral perfusion. Rue says A. Which outcome best shows effective shock management? Joy says she changed her answer. Okay, Joy going with B. What is the MAP? So MAP greater than 65 millimeters of mercury. What MAP tells us? What mean arterial pressure tells us? What mean arterial? I'm not changing the mind? No, sir. Mean arterial pressure tells you. What it tells you? What we know about MAP? Good perfusion. Good. So sometimes you might see the nurses, oh yeah, the mean is like 64, but the blood pressure still there 80. And then before you know it, the mean is like 65 and the blood pressure is like at 90. And we say, yes, thank the Lord. And we feel good. Yes, the patient is perfusing well. So we don't normally always go with blood pressure because you can have the blood pressure looking okay, but the MAP or the mean is still less than 65. That's a problem. That is a lot of work for us. So you always want your mean or your MAP to be 65 over 65, and that is showing effectiveness in terms of what you're doing for your management of your patient. Heart rate alone is not it. All right, heart rate alone is not it. SpO2 is not it. White blood cell count normalizing is not it. So once you're perfusing properly, then your mean arterial pressure is going to be increasing, and so that's how you're going to be able to tell. Okay. I think I never tape on off properly, but yeah, final points. So the final points here, just think about your trends, not single numbers for your, for your NCLEX here and your lab values. And always think about your electrical activities. It's greater than chemical, and that comes before comfort. And brain and heart before your kidneys. Any sudden change is always priority for your patient. And always treat your cause, not your symptoms. All right, and the loudest patient in the room is not priority. Amen. Any questions? Any concerns? It was nice having you guys. Yeah. It's past my bedtime. All right, thank you guys for the follow. Acom, welcome, welcome, welcome. Thank you. Oh, so I normally do on Tuesdays and Thursdays. I'm planning on doing 8 o'clock on Mondays and Thursdays. Oh, let me fix my camera over here for my lovely folks. Oh, I'm gonna put on a filter. They never need it. Not true. I'm already don't see me. But on I'm gonna do Mondays and Thursdays at 8 p.m. just because it's gonna be a little easier for me, because now I can just go and bed and lie down. You know them way there. Where am I? I'm in Texas. Outside freezing though. Yeah. Thank you, thank you, thank you. Thank you, A18. I do actually enjoy the lives. I do enjoy the sessions, I do enjoy the sessions. Yeah, it's very interactive. I learn and it's fun. Please do go ahead and turn on the notification. And as I say, if you missed the live streams that we've been doing over the past couple of weeks, they're posted on YouTube, so you can feel free to go on to YouTube and subscribe. Yeah, make sure you subscribe so you can actually get the full length, and you can watch them at your own convenience. You're welcome. You're welcome. And remember to follow. Follow and check out the other videos that I post as well. And if you're an international nurse, you know, follow me. I talk a lot about nursing, being an international nurse. So, yeah. All right. Good night, Pustain, Sugarcane. Where you come from, Pustain? Because that name just kind of sound Jamaican. I don't know why. All right, I have an Archer code for discounts maybe your students can use. Okay, okay. I can take a look at it. I haven't posted it as yet. Okay, no problem. I'll look at it. All right, thank you, Ansi Blue. Good night to you too. All right, no problem. Oh, you're in Dominican Republic? Okay, all right. Well, I'm gonna go get some sleep and then I'll probably come on tomorrow because it's still icy outside. So I might come on tomorrow and do a live stream. All right, so it was nice having you guys. All right, enjoy. It's the same as the Think Nursing here, one word. So Think Nursing, one word, same as the handle on TikTok. No problem. All right. Okay, no problem. Okay, I will see you guys. Thank you so much for tuning in. Oh, this phone is loud. All right, I'm gonna go on my bed now. I'm so sleepy. All right, well, get some rest and stay safe now. All right, bye.